All right. Welcome back to chapter 44. It seems like I've said 44 a lot, and I'm going to have to say it a few more times, I guess, before it's over with. So this is part 4 of Pediatric Emergencies on chapter 44. We were discussing some cardiac issues when we finished off with part 3. So that's where we're going to pick up on part 4, and we'll start there talking a little bit about some heart failure in pediatric patients. So heart failure is when the heart is unable to meet the body's metabolic demands at normal venous pressures. Infants typically present with tachypnea, retractions, grunting, and difficulty feeding, whereas children will often exhibit profuse sweating, increased work of breathing, and an increased work of breathing during feedings. Older children may show tachycardia, tachypnea, crackles on examination, or even an enlarged liver. Treatment is going to focus on correcting hypoxia, reducing the amount of preload, reducing afterload, and improving myocardial contractility. So basically the heart's not working well. We want to do the things that we can to try to get it to work as best we can with what we've got. Treatment's going to include oxygen, probably some diuretics. Of course, that may not happen in the pre-hospital setting. More than likely it won't. But in the hospital, they'll probably receive some diuretics. They may even get some inotropic medications that could be by protocol or even ordered by medical direction, depending on the severity of the heart failure, and maybe even the history of it as well. Of course, we need to make sure that we use IV fluids carefully, as these patients are at risk of fluid overload. So we want to be very cautious about how much fluid that we give them. So understanding what's going on is going to be really helpful. Myocarditis, it's basically an inflammation of the heart muscle. It leads to myocardial dysfunction that can ultimately result in heart failure if not taken care of or not addressed in time. Most children present with acute symptoms, typically caused by some form of a viral infection or something that's going around. And if it's left to its own devices, it will get worse and may lead to heart failure. Due to the risk of dysrhythmias and hemodynamic instability, we should transport these patients with cardiac monitoring and pulse oximetry in place, which we typically would do. Anyway, establish an IV, but administer IV fluids cautiously. Remember, these are at risk of heart failure, and those patients are at risk of fluid overload because of poor heart function. So, be very reserved on fluids. Inotropic support is often necessary for these patients, so the administration of some inotropic medication may be necessary. Of course, that's going to be very protocol dependent, and of course provide supplemental oxygen during transport. There are 3 main types of cardiomyopathy. There's dilated, hypertrophic, and restrictive. Dilated cardiomyopathy involves progressive dilation of the ventricles, which leads to poor myocardial contraction and low cardiac output, resulting in heart failure symptoms. It is the most common type of cardiomyopathy in children. It is estimated that 30 to 50% of the cases are actually inherited. Other potential causes can include things like infection, nutritional deficiency, toxin exposures, which include, fatigue, weakness, heart failures, maybe even see some atrioventricular dysrhythmias that might lead to this. Hypertrophic cardiomyopathy is an inherited disorder where the heart muscle becomes unusually thick, making it harder for the heart to pump blood. Symptoms typically appear in school-age children during adolescence and may include things like chest pain, dysrhythmias, dyspnea with exertion, syncope, and even sudden death. In infants, hypertrophic cardiomyopathy presents with signs and symptoms of heart failure. It is crucial to thoroughly investigate any reports of unexplained syncope particularly in younger patients or athletes. This is going to be the big giveaway for this. This hypertrophic cardiomyopathy is closely linked to syncope. That's one of the big signs that you'll see with it. So if it's unexplained syncope, you may be on the right path. Restrictive cardiomyopathy is where the ventricular filling is impaired due to a stiffening of the wall of the ventricular walls, which may result in endocardial disease, myocardial disease, or both. Symptoms are similar to those of heart failure. Tachydysrhythmias are commonly observed in patients with restrictive cardiomyopathy. Transport the patient with continuous cardiac monitoring and frequent assessment of vital signs. You can go ahead and establish vascular access, but be prepared to treat heart failure and dysrhythmias based on local protocols or instructions from medical direction. Remember, these are also going to be fluid restricted patients too, so we're not going to pour the fluids to them. So basically, when we just look at the general assessment and management of cardiovascular emergencies, we're going to start with that pediatric assessment triangle that we talked about earlier on in this chapter. Then we're going to move on to our pediatric assessment triangle. Is going to give us kind of an idea of how serious the patient is, and then we can drill down further into that with our primary and secondary assessments. An abnormal appearance may suggest inadequate brain perfusion requiring immediate intervention. So we're talking about cardiovascular issues. If they're affecting brain function, then we know we've got a significant perfusion issue. Tachypnea without retractions or abnormal airway sounds is common in infants and children with primary cardiac issues. This is the body's mechanism for expelling carbon dioxide to counteract metabolic acidosis due to poor perfusion. As cardiac compromise progresses to heart failure, pulmonary edema will increase the work of breathing and elevate the respiratory rate. This is where we'll begin to see signs like poor color, cyanosis, or even mottling that can provide important diagnostic clues to what's going on. From the primary survey, identify the likely underlying causes, establish the patient's priority for transport, and decide whether immediate treatment or transport is needed. If the patient is stable, continue to assess and manage at the scene. After each intervention, repeat that pediatric assessment triangle to reassess the ABCs and track changes and trends that you're beginning to see. All right? So that's kind of your general approach to how we're going to manage those cardiac patients. Again, we may not always know exactly what it is that's going on with them, the specific name of the cardiovascular issue that's going on with them. However, we can kind of pay attention to some of the outward signs that we're seeing to give us a general guideline or direction, whether it's heart related. If it's pump related, remember we're going to hold the fluids back. If it's not pump related, we might be a little more aggressive on the fluids. If we're not sure, we're going to do a slow roll with fluids until we can have a better idea of what's going on, or a better picture of seeing how they're responding to those fluids. Okay, so moving on, we're going to talk about some neurological emergencies, and then we'll round off this part, or this section 4 of chapter 44. We'll round it off talking about some gastric, GI issues with pediatric patients. So pathology and let's see. So neurologic emergencies can range from benign to life-threatening. So it's important that we gather a detailed medical history, including any past occurrences of seizures, shunts, cerebral palsy, or recent traumas or poisonous ingestions. Infants and children can be challenging to assess neurologically, as they may be uncooperative due to a lack of understanding or fear. Focus on assessing their general appearance. That'll be a really helpful way to do it. Ask parents about any subtle changes in the child's behavior, demeanor, or activity levels, and this will help also kind of guide your neurologic assessment. So when we're looking at altered mental status, these are conditions that there's some conditions that may lead to an altered mental status, and these include some metabolic issues, infectious diseases, intracranial structural abnormalities, trauma, hypoxia, of course, poisonings. A child with an altered mental status may exhibit changes in personality, behavior, or responsiveness that are not typical for their age. Possible signs in the child may include things like agitation, combativeness, drowsiness, or sleepiness, maybe even withdrawal, slowed response time, all the way up into complete unresponsiveness. Use the mnemonic AEIO tips to remember common causes of altered mental status, just like we do in adults. So follow that same mnemonic. Run through the pediatric assessment triangle and go through the ABCDs, DEs quickly to try to make a determination that what baseline is, and if there's anything that needs to be taken care of immediately. Pay special attention to possible disability and maybe even dextrose issues. Use the AVPU scale to identify the level of disability. Check the glucose level if they're hypoglycemic. Remember, a serum glucose concentration of less than 40 in a newborn is hypoglycemic, less than 60 in all other infants and children is hypoglycemic, and this is an easily treatable cause of altered mental status that we can take care of. History taking and secondary assessment at the scene or en route may provide clues about the underlying cause of what's going on. The management approach remains the same regardless of the cause. Support ABCs, provide assisted ventilation and airway support as needed. If the child is hypoglycemic, administer glucose at 0.5 to 1 gram per kilogram. The goal is to maintain normal glucose levels. Hyperglycemia can worsen neurological outcomes in patients with cerebral ischemia, so we don't want to overdo it on the glucose. If there are signs or symptoms of an opiate involvement, we might want to consider even administering Narcan. So keep those things in mind. Transport all of these altered mental status patients swiftly or quickly. Assess for increasing intracranial pressure and intervene accordingly. When intubating a pediatric patient with an altered mental status, etomidate is commonly used as an induction agent for patients with septic shock or where septic shock is not suspected. Etomidate is particularly useful if the patient is hypotensive, as it has less impact on blood pressure compared to some of the other agents, so it's kind of the ideal agent, especially where hypotension is concerned. Other options are going to include ketamine, midazolam. Ketamine is a bronchodilator, making it another benefit for patients with respiratory issues, but it can cause an increased bronchuria. It may cause a transient drop in blood pressure, though, and it has the potential to increase intracranial pressure. So if you have some issues there, ketamine may not be the ideal agent. Muscle relaxants like acetylcholine or rock can be used in pediatric patients as well. If increased intracranial pressure is suspected, administering lidocaine before intubation can reduce the rise of intracranial pressure associated with intubation because of stimulating the vagus nerve. Signs of increased intracranial pressure include those Cushing's triad signs, bradycardia, irregular respirations, and a widening pulse pressure. Seizures, they can result from abnormal electrical discharges in the brain. Generalized seizures typically present with abnormal motor activity and an altered level of consciousness. Some children are prone to seizures due to underlying brain abnormalities. Other children may experience seizures due to trauma, metabolic imbalances, ingestion of poisons, or even infection. Febrile seizures are specific to young children and are usually benign. The physical presentation of a seizure will depend on the area of the brain from which the electrical discharges are originating, as well as the child's age may play a small factor into that. Infants have less developed brains, so seizures may be more subtle. Repetitive movements like lip smacking, chewing, or motions that indicate seizure activity can be possible as well. Apnea and cyanosis may also be signs of seizure activity. The prognosis is closely related to the underlying cause. So what the outcome of that is, or how serious that is going to really depend on what's causing it. A febrile seizure doesn't cause brain damage. A seizure that results from head injury or meningitis could lead to long-term neurological issues, though. So, types of seizures. The classification system applies equally to children and adults. So the same seizures that we've seen in adults, we can see in children, and they're classified the same. Generalized seizures affect the entire brain. Partial seizures involve only one part of the brain. The most common seizures are generalized tonic-clonic seizures or grand mal seizures, which cause jerking movements of both the arms and the legs. Then there are absent seizures, or also known as petit mal seizures. These are generalized seizures that cause a brief loss of attention without any abnormal body movements. And then when we look at partial seizures, they can be further divided into simple partial seizures, such as focal motor jerking without a loss of consciousness, or complex partial seizures where we have focal jerking with a loss of consciousness. Febrile seizures affect about 2 to 5% of all children. To diagnose a febrile seizure, the child must be between the age of 3 months and 6 years old, have a fever, and have not had any identifiable cause such as a head injury, ingestion, or meningitis that could be associated with that fever. A family history of febrile seizures in a first-degree relative is the strongest predictor of having a febrile seizure. The seizure typically occurs during the rapid rise in temperature rather than after the fever has been elevated for a long time. So it's that initial spike in the fever is what causes the seizure, and then it's not because they've had a seizure for a long time. Simple febrile seizures are brief. Generalized tonic-clonic seizures lasting less than 15 minutes and occur in a child with no other underlying neurological issues. Complex febrile seizures last longer, more than 15 minutes, are focal or occur multiple times within a 24-hour period. These may be associated with a more serious underlying illness. The post-ictal phase following a febrile seizure is usually short, so the child will often be alert or back to baseline by the time that you arrive on the scene. Depending on local protocols, a child who appears well and has a history of simple febrile seizure may be transported by EMS or by the parents, but they still require that they are seen by an emergency room physician. The outlook for children with simple febrile seizures is really very good, since these are typically benign events. In rare cases, though, febrile seizures that last longer than 30 minutes can cause scarring in the temporal lobe of the brain. Some of these patients may actually develop chronic epilepsy, which is often treatable with other types of medications. When we're assessing seizures, we should pay close attention to compromised oxygenation, ventilation, and signs of ongoing seizure activities. Seizures increase the risk of respiratory distress or failure due to airway obstruction, aspiration, or reduced respiratory drive. A child having a seizure when you arrive has likely been seizing for at least 8 to 10 minutes before your arrival. Consider the child to be in status epilepticus in these cases. Begin treatment to stop the seizure. Status epilepticus is defined as any seizure lasting more than 4 or 5 minutes or consecutive seizures without regaining consciousness in between. Follow local protocols to determine how long a seizure can last before intervention is needed. During history taking, inquire about previous seizures. Use of anticonvulsant medications, illness or injuries, or even possible ingestion of poisonous substances. Find out the duration of the seizure and identifiable characteristics of that seizure. If the seizure has stopped by the time you arrive, treatment on the scene is mainly supportive. Administer 100% supplemental oxygen and begin bag mask ventilation if there is hypoventilation present. For a child experiencing an ongoing seizure, open the airway using the head tilt chin lift or jaw thrust maneuver. If the airway cannot be maintained with positioning alone, considering using a narrow nasopharyngeal airway. Suction for any secretions or vomitus. If vomiting is ongoing, consider placing the child in a lateral position. Do not attempt intubation during seizure activity. This may lead to serious complications like damaging the oral pharynx, broken teeth, and that kind of thing. Intubation is rarely successful during an active seizure. More appropriate care is going to involve BLS airway management and stopping the seizure. Consider ALS airway support as necessary. Consider an NG tube if the child requires assisted ventilation. Evaluate, take a look and see if you can find a good IV site. Get a measurement of the serum glucose and treat any hypoglycemia if it is confirmed. Explore options for anticonvulsant medication administration. Start an IV, but this can be a challenging endeavor. Alternate routes for medication delivery may be necessary. The goal for medical therapy is to stop the seizure while minimizing the side effects from the anticonvulsant medications. The first line anticonvulsant treatment is going to be a benzodiazepine, such as diazepam, midazolam, lorazepam. Any and all of these, though, will cause respiratory depression. So if you give any of these medications, it's important to closely monitor oxygenation and ventilation afterwards. Lorazepam is a great choice for seizure management, has a rapid onset and a relatively long half-life with a lower risk of respiratory depression. Midazolam can be administered via IV or IM or even intranasal routes. It's a really effective anticonvulsant, but with the shortest duration of action among the three of the benzodiazepines. So you're going to have to be prepared to repeat doses if the seizures persist. Any child with a seizure history should be evaluated by a physician. So if they've had a seizure, they should go to the hospital. On-scene treatment is appropriate for children in status epilepticus, but a detailed assessment should be continued during transport. Remember to continuously monitor the child's cardiorespiratory status post-ictally and reassess frequently for any recurrent seizure activity. Meningitis or an inflammation or infection of the meninges, which are the protective coverings of the brain and spinal cord, is most commonly caused by a bacterial or a viral infection. Viral meningitis is more common during the summer months, typically caused by the enterovirus, often presents with gastrointestinal symptoms such as vomiting and diarrhea. The children with viral meningitis appear quite ill, but the condition is very rarely life-threatening. Bacterial meningitis, on the other hand, can be potentially fatal. Children can quickly deteriorate from appearing mildly ill to experiencing a comatose state or even death. In the early stages, distinguishing between viral and bacterial meningitis can be challenging. Always assume it could be bacterial meningitis until proven otherwise. Symptoms are going to vary based on the child's age and the infectious agent. In general, younger children tend to exhibit more vague symptoms. A newborn with early bacterial meningitis, the only symptom may be fever. Younger infants typically present with fever and may show localizing signs of lethargy, irritability, poor feeding, and a bulging fontanelle. Young children rarely exhibit typical meningeal signs such as nuchal rigidity until they are older. Verbal children often report symptoms like headaches and neck pain. An altered level of consciousness and seizures are concerning signs of any age. Projectile vomiting and photosensitivity are common findings. Other signs may be present include the inability to extend the leg at the knee when the thigh is flexed due to hamstring stiffness, or the passive flexation of one leg causes the opposite leg to move similarly. Neonates typically acquire the bacteria causing meningitis during birth. Normal bacteria in the vaginal tract can lead to serious infections. E. coli, group B, streptococcus, listeria, monocytes are common culprits of this. Neonatal meningitis is generally not seen after 3 months of age, so typically it's the worst risk for that goes away. Older infants and younger children are at risk of viral meningitis caused by the enterovirus. And these are most commonly, as mentioned earlier, most commonly seen in the fall and summer months. Bacterial meningitis in this age group is often caused by streptococcus. Pneumococcal infections are becoming less common due to vaccinations that are out there. Meningitis from some forms of influenza is rare, since the vaccine for this was first introduced in the 1990s, so we're seeing less incidences of that. Neisseria meningitis can actually lead to sepsis as well. Meningococcal meningitis with sepsis typically presents with a rash in addition to the usual meningeal symptoms. We might see small pinpoint red spots, or which are petechiae, or purpurea, which are the larger purple or black spots like we see in the image here on this slide. Infection prevention is crucial. About the only way that we can manage this or keep it at bay is preventing infections. Meningococcal infections are very contagious, so we should always follow standard and respiratory precautions with these patients, and use gown, gloves, and masks if there is a suspected case of meningitis. Have the patient wear a mask as well. Children with meningococcal sepsis and meningitis can deteriorate very, very rapidly, so be prepared to intervene quickly on them. Watch for signs and symptoms such as fever, changes in mental status, bulging fontanelles, sensitivity to light, stiff necks, increased irritability, those small pinpoint red spots, or even the larger purple dark spots, and of course the indications of shock that's letting you know that they're progressing, their condition is worsening. Check the glucose levels, deliver critical interventions as required, and initiate rapid transport. Continuously reassess during transport. And of course, remember that a rapid decline is not unusual in these patients, so you're going to have to watch them closely. The patient may require oxygen, airway support, or assisted ventilations along the way. Medical direction may advise IV fluids or medications for seizures or shock symptoms. Hydroencephalus is a condition where impaired cerebrospinal fluid flow and absorption leads to enlarged ventricles in the brain and raised intracranial pressure. Normal cerebrospinal fluid production and absorption are balanced, keeping the total brain fluid volume steady. Two main types of hydroencephalitis exist. There's normal pressure hydroencephalitis. It's a rare form, typically affecting older adults. The cause is not real well understood. And the second type involves increased pressure in the skull. The most frequent cause for high pressure encephalitis is slowed cerebrospinal fluid flow. Common reasons for slowed flow include birth defects affecting the cerebrospinal fluid pathways, tumors, head injuries, bleeding in the brain, meningitis. Although cerebrospinal fluid flow decreases, its production continues as normal, causing an overflow in volume to rise. Most commonly seen in children born with brain abnormalities, premature infants, or patients post-brain tumor surgery. Symptoms may appear slowly over months or rapidly over days. Symptoms depend on the patient's age and the underlying cause of it. Infant symptoms might include things like an enlarged head due to a soft skull, sleepiness, fussiness, vomiting, downward eye deviation, tight or bulging fontanelles, and maybe even seizures. Symptoms in older children and adults are going to present with head pain, nausea, forceful vomiting, blurred or double vision, poor balance issues, clumsiness, memory issues, and mood changes. Shunts are often placed to reduce this pressure. There's ventriculoperitoneal and ventriculoatrial shunts that are inserted into the brain ventricles. These shunts direct the fluid to the abdominal cavity. One of them does, the VP shunt does. The VA shunt directs it to the heart's right atrium. The tubing for these may be able to be felt along the side of the neck. And in skinny or very slim or small children, the tubing coils may be felt in the belly. Shunts prevent this dangerous brain herniation by relieving the excess cerebral spinal fluid. So basically all they're doing is creating a drain and a place for that cerebral spinal fluid to drain to. Shunt-related complications can include things like infection, blockage, and even draining too much fluid. If too much fluid is removed, the brain may sag under its own weight, potentially leading to tears and bleeding inside the skull. If not enough is drained, pressure inside the skull rises up. Signs of a shunt not working properly can include nausea, vomiting, head pain, changes in alertness and behavior, and vision problems. With infections, signs like fever, redness, or soreness around the shunt site. Patients with VP shunts may also develop peritonitis if the shunt becomes infected. So here we see a little guy with the downward gaze as well as the large encephalitic head. So we're going to treat these with transport promptly to a hospital with the ability to do pediatric neurosurgeries. As the child grows, the shunt tubing may become too short and require to be replaced. So we're going to provide routine emergency care. But we need to be ready to address seizures and other signs of increased intracranial pressure. These patients often have complex medical histories, and family members can offer important insights into what their overall history is. Avoid handling or adjusting those shunts, those VP shunts, when they're in place. So avoid, messing with them so you don't dislodge them. Traumatic brain injuries. These injuries occur frequently in children. Even children who seem low risk can still have serious brain injuries. Many states require medical clearance before a child with a suspected concussion can return to playing sports. The main objectives are to detect traumatic brain injuries and prevent worsening or further damage. Always consider possible abuse when assessing head injuries in children, though. Epidural hematoma. This occurs when there's bleeding between the dura mater and the skull. It's pretty rare in children, but may follow a low-speed fall. Many cases in infants and young children are due to abuse, while car accidents are the primary cause in teens. Less common in young children because the middle meningeal artery isn't attached to the skull until around the age of 2. This makes it less likely for temporal skull fracture to tear the artery. Fast diagnosis is essential. This may show up as unconsciousness or changes in mental status. Symptoms can include severe headache, repeated vomiting, and unsteady walking. Infants may be hard to soothe and could have swelling in the scalp. Older kids might seem fine for a while after the injury and suddenly get much worse. Subdural hematoma is when there's bleeding between the dura and the arachnoid layers of the brain. This is often seen in babies, especially under the age of 4 months. This can result from injuries during birth, falls, physical abuse, or shaking injuries. Always consider abuse in infants or toddlers with subdural hematomas until that's ruled out. Assume possible neck injury and protect the cervical spine as well anytime there's a suspected epidural or subdural hematoma. Avoid low oxygen levels to prevent further brain damage to the tissue. Vomiting is very likely in these, so suction when necessary. Give supplemental oxygen as needed. Be ready to support breathing if it becomes insufficient. IV access is usually needed for epidural hematomas, but less commonly used for subdural bleeds. Check with medical control to determine the correct fluid administration rate with these patients. If blood pressure is low, assess for the possibility of internal bleeding. Manage any seizures that occur appropriately and according to protocol. And of course, conduct frequent neurological exams throughout the time that you have with this patient. Ongoing evaluations are key to catching signs of rising intracranial pressure with these patients. All right, so gastrointestinal emergencies with pediatric patients. These gastrointestinal emergencies are frequently seen in children. During fetal development, the intestines form outside of the body before moving into the abdomen. Improper development can lead to certain GI conditions in children, such as meckel diverticulum and malrotation with volvus. Some organs, like the liver, continue to mature in the early months after birth. We may wind up with things like biliary atresia that appears in the first, it may appear in newborns. This is where the bile ducts are abnormally formed and prevent bilirubin from being eliminated from the body. This can cause liver damage and eventually lead to liver failure. Rare genetic conditions can also result in liver failure. These children might develop esophageal varices, which can cause severe bleeding, or other things. In cases of heavy GI bleeding, transport promptly to the nearest emergency department, start an IV, and give fluid boluses as needed. Viral gastroenteritis is caused by various viruses or consuming certain foods like milk or even ice cream in lactose intolerant individuals. Other unknown substances have been known to cause gastroenteritis as well. This typically presents with stomach pain, nausea, vomiting, maybe even diarrhea. Fever is also common with this. Vomiting and diarrhea can rapidly lead to dehydration in children. Of course, as mentioned previously, if dehydration is suspected, start an IV. Give 20 mils per kilogram of an isotonic fluid. You can repeat that up to maybe 3 times while en route to the hospital to try to get them stabilized. Appendicitis is relatively common in pediatrics, and if untreated, it can lead to peritonitis and even shock. Typically presents with a fever and tenderness in the lower right side of the abdomen. Pain often starts in the periumbilical area and then migrates down to the right lower quadrant, usually over the course of several hours. Some patients may have fever and vomiting along with it. Rebound tenderness may be present, though this is not super specific to appendicitis, so just because you have rebound tenderness doesn't mean it's a direct indication of appendicitis. Constipation can also cause significant abdominal pain. Pain typically follows a meal and is intermittent. Patients experience diffuse abdominal pain without guarding or rebound tenderness. The severity of the pain can resemble an appendicitis when they're constipated. Never assume that you can differentiate between appendicitis and constipation without further evaluation. So it may seem like you transported someone to the hospital that was constipated and you thought it was appendicitis that you overreacted. That's not uncommon. The signs and symptoms are relatively similar, so they can be difficult to distinguish. So regardless, if it looks like an appendicitis, you need to transport them immediately to an emergency department that can, provide emergency surgery. A common cause of gastrointestinal complaints in pediatric patients is the ingestion of foreign bodies. So what happens is a foreign body becomes lodged in the esophagus and the patient presents with a gagging or vomiting or difficulty swallowing. Increased pain raises the concern for perforation of an organ. Difficulty breathing or choking suggests the potential foreign body airway obstruction. Keep the child in a calm, comfortable position, often the patient on the parent's lap, and transport immediately to the emergency department so they can see about what ways they can use to get that removed. GI bleeding is rare in the pediatric population. The causes are often different compared to adults. Due to the rapid transport time in the pediatric GI tract, upper, lower, and ingested bleeding may all present with hematochezia or bright red rectal bleeding. In adults, upper GI bleeding may present as melena or dark tarry-like stools due to the digestion of the blood in the GI tract. In newborns, blood ingested during birth may result in rectal bleeding. This typically appears in the first few days of life and is harmless. Infants may also have blood in their stool if there is maternal bleeding during breastfeeding. Maternal metastasis, an infection of the breast, is a common cause of bleeding during breastfeeding. In children, ingested blood can come from epistaxis after surgery like tonsillectomy or after repeated doses of forceful vomiting. Gastroenteritis and recurrent vomiting can lead to small tears in the esophagus called Mallory-Weiss tears. These can present as blood streaking in the emesis or blood in the stool. Usually small, harmless, and self-limited. Constipation can cause small anal fissures that lead to rectal bleeding. Blood from fissures typically present as blood streaking on the surface of the stool and painful. They are painful but typically self-limiting. Abusive trauma should always be considered in the differential diagnosis of rectal bleeding in pediatric patients, so we should suspect that there may be something else going on. Intraception is most commonly occurs in children between 6 months and 6 years of age. This is where the bowel telescopes onto itself, often happens in the small intestine folding onto the large intestine. This presents with intermittent severe abdominal pain, lethargy, blood in the stools, and the blood often resembles kind of like a jelly-looking substance. This is a true surgical emergency and immediate transport is needed. Meckel diverticulum is one of the most common congenital malformations of the small intestine. Typically presents with painless rectal bleeding or hematochezia. Often follows the rule of twos. It affects 2% of the population and has a 2-to-1 male to female ratio. Located within 2 feet of the ileocecal valve, usually 2 centimeters in diameter and 2 inches in length, and contains 2 types of ectopic tissue, usually pancreatic and gastric. Most are symptomatic by the age of 2. The causes they can cause a significant concern due to the large volume of blood loss. If suspected, we should transport them to the emergency department for further evaluation. Most of these patients that are presenting with rectal bleeding, we're going to transport them for more evaluation. Pyloric stenosis and malrotation of the volvus, or malrotation with volvus, typically occurs in infants younger than 2 months. The pyloric stenosis happens when a pylorus becomes hypertrophied. Infants present with projectile vomiting that occurs after feedings, poor weight gain or weight loss, dehydration, and electrolyte abnormalities may occur due to frequent vomiting. And of course, surgery is going to be what's going to be the cure for these. The malrotation with volvus is a twisting of the bowel around its mesenteric attachment to the abdominal wall. Patients typically present with pilus emesis or dark green emesis, abdominal pain, and a distended rigid abdomen. Blood may be present in the vomitus or stool. And of course, this is a surgical emergency, so transport immediately to an emergency department with pediatric surgical capabilities is going to be essential. General assessment and management of gastrointestinal emergencies are going to kind of follow along the lines of, we'll take into account the patient's age, sex, and prematurity at birth. Inquire about medications that are being used and any history of similar gastrointestinal issues. And of course, severe abdominal pain is a common complaint with a wide range of potential causes. However, recurrent abdominal pain that mimics appendicitis may also be due to constipation or gastroenteritis, so don't automatically leap to conclusions. Patients using polyethylene glycol may experience abdominal pain from constipation, while those on H2 blockers like Redantine may have gastritis or ulcers. Look for signs such as poor color or jaundice, including scleral jaundice, which could indicate hepatic disease or blood loss or breakdown. Tachycardia is typically seen before hypotension, so treat with an IV fluid bolus of around 20 mils per kilogram. Regularly assess the location and severity of the abdominal pain to monitor for changes. Premature infants and those with symptoms in the first weeks of life require evaluation at a center equipped with pediatric capabilities. Special attention should be given to patients with gastrostomy tubes, as they may need continuous feeds to maintain hydration. G-tubes can become dislodged if the child plays with it or pulls on them, or if the balloon securing the tube deflates. Many parents are trained to replace G-tubes themselves, so it doesn't always result in an emergency call to EMS. If a replacement tube is unavailable, inserting a sterile urinary catheter or similar catheter into the stoma is crucial. Stomas can close quickly and completely after the tube has been removed, so leaving the stoma open is not an option. Reinserting the original tube into the stoma can help prevent this, although it's not ideal. When replacing the G-tube or inserting another catheter, consider the age of that opening or tract. Mature tracts, the ones that are over 6 months old, can generally be safely replaced. Avoid replacing G-tubes or inserting new ones into immature tracts in the field due to the risk of the tract perforating or you winding up with improper placement into the abdominal cavity rather than into the stomach. So those are not something we're typically going to try to do if it's a relatively new placement of a G-tube. So apply water-soluble lubricant to the end of the G-tube before inserting. Use gentle pressure to allow the tube to slide into the stoma. If there is significant resistance, pain, or bleeding, abort the attempt immediately. Once the tube is in place, tape it securely. Transport the patient to a hospital for definitive replacement if necessary, and bring the old to the hospital with you for inspection to aid in the assessment of any potential issues that may be present. So then we want to ask to determine the hydration of the patient. We might want to ask a few questions like, how many wet diapers has the child had? Is the child tolerating liquids and keeping them down? How many times has the child had diarrhea and for how long? And when the child cries, are there any tears present? During transport, of course, we're not going to give anything by mouth, nothing to eat or drink until a thorough assessment can be performed and completed by a healthcare provider at the receiving facility. Vascular access is often indicated if signs of clinical dehydration are present. And of course, we're going to keep the patient comfortable on cardiorespiratory monitors and perform frequent assessments for any changes in their hemodynamic status along the way. All right, and there it is. Part 4 of chapter 44 is in the books. I will see you guys back in section 5 of chapter 44.